Thank you very much. First of all, my thanks goes to the organizing committee for giving me an opportunity and the wonderful arrangements the team from the Tapisar have made for the past 3 days. My congratulations to them for doing a wonderful job. In this lecture of about 20 minutes to 25 minutes, I'll be taking you through a journey which was different from the previous speakers. The first speaker was speaking about the infectious destruction that happens in the humanity. The second speaker was speaking about regenerative medicine. The third speaker was speaking about conservation of the reproductive organs through surgical methods. And now I'm going to speak about what nature is doing and not what we are not thinking about. So it's basically mostly a theoretical lecture with evidence to put a flashlight on these thought processes which we have ignored for almost a couple of centuries. So we always say elderly mother, elderly woman, but why do we not say elderly man for the same age group? We say 35, 40, then you say high-risk pregnancy, elderly woman, even though physically, emotionally, she's a normal person, but we label them in that because of the risk it is associated for the pregnancy outcome. And these have been identified for almost a large number of years. And as the age of the marriage is changing with time, the number of women who are planning their pregnancy at higher age is increasing. Similarly, the same trend is happening, but unfortunately, the professional societies have not come with any guidelines about advanced maternal age. They are clear-cut guidelines of female advanced age, and they put a cutoff of 35 years. But in male, just because sperms produce throughout life, it does not mean they don't have cutoff age. Similarly, there is no definition for advanced paternal age, some say APA. And in the literature also, there is no consensus whether it's 40 years, 45 years, 50, 70 or 90. So here I am going to present the implications of advanced paternal age in relation to 40 years and 45 years. And it has a lot of effects. So I'll be speaking from the human body aspect, the testis, the sperm production, what happens when an advanced paternal age person has a partner becomes pregnant and its implications, and what are the implications for the child. One thing is we never realize the time to conception is different and it is longer for advanced paternal age. That change starts at 34 years and starts peaking at 40 years, and they take more number of months compared to normal population. Just because we don't document and there are very few publications, we are not coming across those areas and then thinking it doesn't have any bearing. If the partner is of a higher age, they take longer time to conceive, and we are not co-factoring the combined age of the couple when we're looking at the reproductive medicine. And this work has been done many years back in 2001, but subsequently it was forgotten until again in the last 5 years, a lot of attention is coming in. When you look at the hormones, the hypothalamo-pituitary testicular axis is disturbed with age of more than 40 years. It affects on the androgens. The FSH is slightly increased. The testosterone levels are decreasing, but we are not having large amount of data to say that this is a reproductive effect. Sometimes we are correlating testosterone to a metabolic disorder or a risk for a health problem rather than an aging phenomena, which we should start looking at. The other area is the paternal age. There's a decrease in the sexual frequency and a significant change is there. But there's a lot of lack of data because most of the time either we don't ask or the truth is not told in an accurate way. When you look at testis, just because the size does not change, it does not mean there's no change in the components of the testis. the Satori cell number decrease, the Leydig cell number decrease, the germ cell decreases, the thickness of the basal membrane of the seminiferous tubule increases, but the testicular size does not change till the age of 80 years. Just because it did not change, we forgot to work up the male as a contributive factor for disturbance of reproduction. This is a very old publication published in 1985 where they looked at the effect of aging, malnutrition and illness and testicular size, and they found that unless the person reaches 80 years, the testis does not change in the size. But they did not say it did not malfunction, but we took it as just because the size did not change, we are taking it, it's not malfunctioning. So when we come to at the cellular level, there's a decline in the Leydig cells, a decline in the sartorially and the germ cells. Here in the next slide, I'll be showing you the concept what happens in a young person at the stem cell level and how the stem cells are changed. There are two types of stem cells, the pale one and the dark ones, which are in the regeneration, and that metabolisms are changed. Here, this is the stem cell, and this is the spermatogonia, and spermatocyte, and elongated spermatid. And then the pale and the dark stem cells keep on changing in a dynamically way, and they are retained. But when the age becomes a factor, this is disturbed. So you have a state of reduced function, but we are only looking at this sperm and looking at the WHO values and saying whether they're falling into the 5th percentile and the 95th percentile, and then saying there's no role for man. So this is what I would like to re-emphasize. There's an interesting study which came quite some time back, and they found the changes in the sperm function starts from the age of 34 years. That is quite an young age, and there are very few studies. And just like Pai said yesterday, we don't have Indian data nor large amount of international data about normal sperm population and the studies. His initiative to find out and do a 10,000 seminanalysis of normal fertile men will make a difference for us for future, not for infertile people. So when it comes to advanced paternal age, the decline in the semen volume, motility, morphology, and total count, and these publications have been quite a few in number, but more so in relation to the pregnancy outcomes, there is an increase in the DNA fragmentation, especially in the area of protamine and also in the ratio of the protamine gene 1 and 2, which affect the chromatin packing. So DNA fragmentation is playing a significant role, but that is not just the story. In this slide, an aging sperm has an abnormality of telomerase length, then it has higher DNA fragmentation, then it has also ability to produce microdeletions into the next generation. And not the least, but the most important thing is it produces a lot of de novo mutations. The mechanism of a female woman producing an abnormality is by aneuploidy, and the mechanism of a male producing abnormality in the offspring is by de novo mutations. The mechanisms are entirely different. So the impact of advanced paternal age on male fertility status is there, but when it comes to assisted reproduction also, the same effect is seen, but we are not analyzing the data. We are just looking at the female age, number of oocytes, embryos, but not adding the confounding factors and not doing the analysis in the true way it is supposed to be done. Here in this slide, you're seeing the pregnancy and embryo transfer rates in relation to couples' age undergoing IVF cycle. And then as you see on the x-axis, you have the woman's age with the graphs plotted in the less than 35 years male, 35 to 49 years, and 50 to 83 years group, with the female partner at the different age. And then you see from the age of 35, you're seeing a significant decline in the pregnancy rates and carry home baby rates. So apart from the pregnancy, are there any effects of the advanced paternal age with an elderly woman on the effect on the child? The answer is yes, but we don't pay any attention. The major areas where it can produce changes are, it can produce impaired germ cell abnormality, DNA damage, DNA methylation, and spermatogonadal changes, which might have impact on the future. So in the next point when we look at it is there any relation in IVF and non-IVF cycles of paternal age and abortion? The risk of abortion between 6 weeks to 20 weeks is significantly changed as the male age in the x-axis increases. And then in the next slide, you have a matrix of using the combination of paternal age and maternal age and the risk factors. When you have a paternal age of a certain age group with a much younger woman, the impact is not so much, but it's still there. Whereas when both partners are a higher age, the risk factors are significant. This is another area where we are not concentrating in our failure analysis. So when we look at elderly couple, or I don't say elderly couple who are at around their 40s, conceiving, their implications to the next generation is also there. Another interesting thing you also see is when there is a paternal age of more than 45 to 49 age group, the instance of preeclampsia in their partners are high. The paternal age effect shows a U-shaped increased risk for preeclampsia, with highest risk in men aged 45 years and older. And men who fathered a preeclamptic pregnancy in one woman are more likely to father a preeclamptic pregnancy in another woman. There are two dimensions of this information. But if you ask me what is my personal thing, because I have not been looking into this only in the past 1 year, and more so this lecture has opened my eyes to a new field where it is seen every day, but we are putting a blind eye. That's the lessons I learned from this visit. Regarding cesarean section, it can be because of the high-risk pregnancy or an indicated one. But the next thing is the birth defects. As the male age increases, the odd ratio is increasing at a significant high rate. What is the impact of advanced paternal age in men on their progeny? They are huge. It starts with achondroplasia, Alport syndrome, retinoblastoma, neurofibromatosis, Down syndrome, Klinefelter's, epilepsy, childhood cancers, leukemia, and breast cancer. But I'll be pointing out the problem at the gene level called selfish spermatogonal cell selection at the gene level, where there is a change in the DNA fragmentation by the FMXR gene when it's chromatically packed, and they say there's a change in the alkaline to acidic status, and they are more predisposed to selection. So they labeled this concept as selfish sperm selection method, and they were specifically studying only for achondroplasia and for Alport syndrome. When we look at what are the effects on the thing, you have syndactyly, caniosynthesis, you have facial dysmorphism, you have Marfan's or achondroplasia, then you have cardiac abnormality, and the neurological. So when you look at the case of spontaneous case of achondroplasia with paternal age and the frequency of FGFR3 mutation, you're seeing a significant increase even though the male partner's sperm and DNA fragmentation is high. So the impact of advanced paternal risk on genetic disorders is significant. But there is another dimension, that is the role of psychiatric disorders in paternal age children. They are produced by DMO mutation, and there are risk of 5 disorders which are significantly increased in children born of older parents, be it natural or be it assisted reproduction. The areas of these offsprings are, one is there is an increased risk of schizophrenia, autism, bipolar disorders, behavior abnormalities, and cognitive ability. So based on this, there is the hypothesis called denomutation, epigenetic alteration. These are the 4 hypotheses. But at the molecular level, they found the red dots, which I said, which I like move over, are the changes that happen in these people. So at this moment, there are no challenges are how to identify it, what are the strategies that are needed to mitigate the impact. And one of the groups suggests that when there's a paternal age of 50 years and above, the couple where if it's a natural pregnancy, to order an NIPT and look at these 5 genes and then counsel them the risk factors. In summary, the impact of paternal age is having on the physiological condition, then at the gene level, then at this moment, except suggesting assisted reproductive technology for the conception, we don't have any proper solutions, and only time will answer. And the first step is having awareness of the problem is the first thing before answers come in. I thank the audience for the patient hearing.
Thank you, sir, for that informative lecture on the implications of paternal age. Hardly we record the paternal age in our obstetric case. You said eclampsia and cesarean delivery. Maybe we have to take that into account also. But mostly we come across autistic disorders in children who have a spectrum of autism. We go through the paternal age. They say the paternal age has a major contribution towards it. Maybe still we don't have much data to say, but in reproductive, in medicine, do you take age as a consideration before going in for infertility treatment?
Past 2 years, especially for somebody who lost a child and the partner is 38 to 41 years, 40 years female partner, comes for this procedure, I tell them apart from the Down syndrome, schizophrenia and the mental disorders literature is there, and I don't have any test to do that, but that's a fact you should be aware of. And in fact, last week I was speaking with a psychiatrist colleague in US who's working in schizophrenia. Then I asked him to check his database. What was the child order? What was the age of the patient's father at the time he was born?
The child was born.
And they found a significant association. Now they're going to plan a larger US study based on this information.
Thank you, sir. Thank you, sir.